Great. So we know you've got some burning questions. We're going to start with some questions from our webcast site. Do we have one ready, Liz?
You want to put your hands up and I'll come around?
Yeah, so feel free to raise your hand.
Are you ready?
Go ahead.
I'm from Sonoma County, and we're looking at investing in evidence-based practices and for the treatment of perinatal mood disorders. And I'm really trying to figure out what the best solution to that is. And so I don't know if people who are, what you consider like evidence-based practice. We're doing interpersonal therapy, which we have on our upstream, but is that we're looking at moving beyond depression, which is a particular cognitive behavioral therapy that's designed, and we're just trying to figure out if it's sustainable if we actually invest in that kind of training. So that's the dilemma.
Gabrielle or Marguerite, do you want to try to answer that question?
I'm going to fight with her.
Well, unfortunately, at my agency, we have 13 programs, and we only have one evidence-based program, and that's our Healthy Family America, but it's not a master's level program. We have an infant mental health program that's just like our Strong Beginnings. I just call Strong Beginnings infant mental health for African Americans, but it's not evidence-based, but they are my aim is working on getting that evidence-based. We have a lot of theories and models that we use that are evidence-based, but as far as a program for postpartum depression, we don't have one at our agency that's evidence-based yet.
So what we found is not just like no maternal mental health disorder looks the same in any other woman, it's not a one-size-fits-all kind of approach. We do use IPT. We also talk a lot about the dyadic psychotherapies because we really find that since the infant is not only impacted but can actually contribute to treatment for the mother, that involving that infant. So we look at CPP and a couple of the other programs, I think Healthy Families as well. There's a wide range of programs that are working towards that dyadic work. CBT tends to be evidence-based as well, but group therapies can be really helpful, and there are many different approaches, so I don't know which evidence-based approach it would be. So I don't know if that answered your question at all. The question of sustainability, if you figure that out, will you let us all know?
I can just add one thing to that. We're using IPT with most of our moms with postpartum depression, but we've just started looking into training on the STARE intervention, and it's specifically for trauma. We've found that although we've used trauma-focused CBT or TF-CBT, it's not quite enough for some of our moms who've had 25 years of trauma and it's just coming to light with the birth of their child and it's been untreated this whole time, and so 12, 16 sessions of TF-CBT don't quite cut it. So STARE, S-T-A-A-R, but we haven't gone through with it yet. We're just getting trained on it this month. But I would say those are the IPT and TF-CBT and some deeper trauma-based work.
One way or another, one thing that we've been talking about is the result of lack of supportive parenting. The low-hanging fruit there is that huge piece of the population that has had no personal experience with supportive parenting themselves. Many of whom might do better if they only had some idea what it looked like. So the thought that keeps coming back to my mind in terms of primary prevention relates to the idea, since we're dealing with literally tens of millions of people who would be the target audience, essentially you're locked into broadcast television as the vehicle. What if one were to develop a pilot for serial program, having woven into the storyline illustrations of what supportive parenting looks like and how it plays out over time, contrasting that with illustrations of destructive parenting and how it plays out over time. I keep thinking somewhere there might be a graduate student who would find this an interesting PhD thesis topic to develop a pilot for such a program.
Can we pass the microphone?
So Oregon Research Institute has done research on showing parents videos of positive parenting and then coding how those parent behaviors change over time just from those small interventions. And actually Triple P does have an online intervention, and they've actually really upscaled their videos based on some of that research. So I think that people are doing that. So.
I think we have a few folks in entertainment, or at least connected to folks in entertainment in the room. So interesting idea. We've got to see where that goes.
Questions?
Do you want to comment?
Can I make I just want to make a comment. A lot depends on when do you want to start the intervention. Because I think that when I look at preterm birth, I've been trying to reduce preterm birth for 35 years. We have not been very successful. But when you look at the evidence-based part of it, the Cochrane databases, and start looking at what things make a difference, there is evidence-based for behavior modification, but it's not really, it's significant, but barely significant. The use of progesterone significantly reduces the risk of preterm birth in women who have recurrent preterm birth. Now, with our vitamin D studies now, it's very clear that vitamin D is important. There are randomized trials now, 2 of which have been published, to show a significant effect on preterm birth. But it's a combination of things. So I think you have to begin to look at not just one intervention, a combination of things that work together, because we're talking about systems biology. And every system is affected, and you got to address these. It's very complex. Diseases are complex.
Great. Liz, you want to ask a question? And let us know what site this is coming in from.
Sure. So John at Denver Children's had a question for Dr. Morgan. In reference to the video that you showed in the beginning of your presentation, he wanted to know, did they factor in the age of African American mothers at birth? And did they also factor in the marital status of African American mothers? And he was curious to know if they were compared to Latinos at the same data points.
They weren't compared to Latinos at that time, but they were compared to Caucasians. And if we would have had time to see the whole video, they did show a correlation that even Caucasian mothers who were dropouts had a better birth rate and their preterm and low birth weight than educated African Americans. They did have some information around marital. The lady who would be the primary person in the video was a lawyer. And she did everything right. She was middle class, educated, ate right. They show pictures of her at the farmer's market, buying the fresh fruit, walking around her beautiful collie stock. That's what we call it in Michigan. I don't know what you call it here, where you have the nice area where you can walk around in a circle. And her and her husband, married, had everything, and she still had a baby that weighed 1 pound. And so factoring in all that, and she also shares some of the things that she experienced, that even though she was higher educated, and we were trying to figure out when we saw the movie, or did she not make partner? That's the only thing I could think about around her racism, when we saw it, but they didn't really say what other stuff she was going through at that time.
Any other questions in the room before we move on to more webcast questions? Let's see if there's one in the back first.
For Dr. Hubble, I was just curious, what dose of vitamin D are you recommending, and what dose of omega-3s are you recommending?
Vitamin D, what's in a prenatal vitamin is around 600 international units. So if a woman's deficient, it will not correct the deficiency. So you have to take at least 3,000. The studies that have been completed now use 3,000 international units a day. It's between 2,000 to 3,000 international units, and it's safe. We have not seen any complications from this. None have been reported.
But that's based on having drawn a vitamin D3 level first, right?
Well, this is a problem today because it's expensive to draw to get vitamin D levels routinely. When 40% of people are either insufficient or deficient, it's probably not cost effective. It's safe. So now the only problem we've seen is in children. If children are overdosed with vitamin D by mistake, then you can develop hypercalcemia. And we've seen 2 cases in the last 2 years at Cedars of vitamin D toxicity in children, but none in adults. Now, omega-3s, I think it varies a lot. And the metrics are hard to understand. And there are 2 different forms of omega-3s. And one's for cardiovascular health and one's for brain health. And it's important that it's taken. I don't think you have to give any recommendations for dose. When you go to the pharmacy or you go to Whole Foods and look for it, it's somewhere in between about a total of 800 milligrams of omega-3s.
Great.
Thank you.
Liz, any other questions? Up here, do we have a question? We have one up here.
Not sure why they gave the pregnant lady this job of navigating through.
Thank you. I had a question on the ACE. We're using the ACE collecting data in our 0 to 5 program in San Bernardino County. And one question that comes up a lot is the question about separation and divorce. Since we're dealing mainly with the Medi-Cal population, and probably true in all kinds of populations, so many of these mothers have never had, not only aren't married or haven't been married, but maybe haven't had a father in the picture practically since conception. And so clinicians are confused as to how to answer that question in that case and are often giving them a 0, and I'm not sure if that is right.
I think the basic point that we're after is the absence of a second parent, a second male parent. The minute details of that we did not study. That would, frankly, we'd have no interest in it because I see it as a huge amount of effort to gain very little back. I mean, the main point seems to be the absence of a male parent.
Okay, great. That's helpful because we weren't sure whether it was the absence or the loss. So it's like if you never had one, then...
Sure. No,
know.
in our mind, it was clearly the absence.
Excellent.
Yes.
Thank you. That's helpful.
I have a question for Dr. Briggs. Can you talk to us a little bit about billing and sustainability of your model? You can't get off the hook without answering that question.
How long do you have?
Yeah, right.
I can tell you the following. I can tell you that, of course, Medicaid rules are very state-specific in terms of what you can bill for. There are codes called the Health and Behavior Assessment and Intervention Codes. They're the 96150 family of codes. They're turned on in New York. They're not in Colorado. I don't know about California. Look into them. They're codes that you can bill for when you're doing counseling or supportive work around something other than a mental health diagnosis. And so it seems to be just about the only code that we can use for true prevention work with children. When the child doesn't have a mental health diagnosis, if we're doing our job right, but say they have a speech delay or say that they have asthma or say that there's some other problem. So that's a code we use. For the parental mental health services, we bill the parent if they have insurance. We make a separate chart for them. It doesn't matter that they're in pediatrics. We just bill the parent under regular psychotherapy codes. We have a CMMI grant right now, the Center for Medicaid and Medicare Innovation grant. We have a large grant to look at payment reform. And if I were to be very honest with you, I think the future is away from fee-for-service billing. I give you a bill, you pay me $12. That's not sustainable. The future is some sort of combination of what's called capitation or full risk payment. You can call it whatever you want, but the idea being in the model that we're testing out in 6 of our 21 practices is that the practice gets a quarterly payment per patient and can do whatever they want in terms of providing services, but doesn't drop a bill. The only final thing I'd say that I think an even more promising approach is what they're trying to do in Massachusetts right now. They've taken the Massachusetts Medicaid and they've divided it into 3 tiers. And they've the same idea of a capitated quarterly payment, but the payment is based on where you fit in these 3 tiers. The lowest payment is if you're just a patient-centered medical home, if you've reached PCMH through the federal standards. The second payment, which is a bit more money, is if you're a PCMH plus a social worker or a psychologist. And the third payment, which is even more money, is if you're all of those things plus the presence of a psychiatrist. And I think that's an even smarter payment model because it's really paying for the staffing that you need in order to provide the services.
Great, thank you. One last question from the audience, and then we'll wrap up.
I have a question about the ACE study. In your practice, you're asking other questions that medical trauma, war service, and I'm wondering if you're looking at a revised ACE 2.0.
No, not if I understand the question. I mean, the ACE study was carried out as a discrete entity in conjunction with comprehensive medical evaluation. Later, we saw the necessity of integrating the two just to keep it as a ongoing process. I think that's the better way to do it. I would like to stress what I am convinced is the importance of collecting this information by an inert mechanism initially. In our example, with a very well-devised paper-based questionnaire filled out at home. We've now used that with 440,000 adults over an 8-year period. It really works very well. The problem with doing it face-to-face initially is that essentially all of us are uncomfortable initially with those questions. I mean, we've all been taught as children, you don't talk about stuff like that, etc. And so it's done clumsily and pretty short order to save our own embarrassment, we'll just stop doing it. There are all sorts of interpersonal difficulties. Well, I mean, this old white guy, he's not going to understand me. You know, this doctor's too young. He's not, I'd rather talk with a lady doctor about this. I'd rather talk with somebody who's Korean like me, etc., that would understand. For unknown reasons, those issues appear to disappear when an inert mechanism is used initially. And so we found remarkable ease when people showed up 10 days or so later in the exam room to bring this up in the way, I see on the questionnaire that. Can you tell me how that's affected you later in your life? I see on the questionnaire that you were the one who discovered your father's body when he hanged himself. How has that affected you later in your life? On the questionnaire that you were molested a number of times as a kid. Can you tell me how that's affected you later in your life? And we listened, period. And totally to our surprise, believe me, to our surprise, we find this huge drop in doctor office visits afterwards. And remarkably, people were pleased and grateful, and they made that explicitly clear that somebody finally asked, that someone seemed to care, that someone seemed to understand.
May I just add one thing?
So even better probably than the paper-based would be to put it into a digital format on the internet. And that's what we're working on now, or I'm working on as a private individual now, so-called North American Health Index. Initially English, then Spanish, then Canadian French, and then God knows where.
Can I ask a very quick follow-up to that? So you're saying
Sure.
just the fact that you have that brief conversation with the doctor is enough, or do many of them get referred then to counseling?
Oh, I'm glad you asked that, because most people hearing that have said to me, 35, how'd you do that? You sent everyone to therapy, right? No, we essentially sent no one to therapy. So how'd you do that? Well, we spent a lot of time thinking about, how did we do that? Because we weren't aware it was happening. And on reflection, I slowly came to see that asking by an inert mechanism initially, and listening and implicitly accepting is a very powerful form of doing, especially when the subject at issue has been held in deep secrecy for a lifetime. Essentially, I came to see that's the role of confession in the Catholic Church. No, I'm not joking, and I'm not saying this as a religious person, because I'm not. But that approach has been used for about 1,800 years, and the essence of it is that one individual tells something shameful about themselves to someone who's important to them. In our instance, it was a physician or a nurse practitioner, and comes to realize very, very soon, minute, 2 minutes, that somehow they still seem to be acceptable to this important person, who now understands something terrible about them and still seems to think they're okay. So that, I wish I had known that 50 years ago. It would have made my life and a lot of other people's lives a lot easier and better. The idea of asking and listening and implicitly accepting. In most of my career, I've spent, what am I going to do? So it was a big change.